And joining us tonight on the debate for the full hour, in Providence, Rhode Island, Dr. Peter Kramer, that's him on the right. He is psychiatrist and author of Listening to Prozac. And also in Providence, Gary Greenberg, psychotherapist and author of Manufacturing Depression. Now, with us here in studio, Brenda Smith, a family doctor from Curtis, Ontario. Erick Fabris, psychiatric survivor is what he calls himself, and peer advocate. Jody Lofshe, director of psychiatric emergency services at the University Health Network in Toronto, and David Goldbloom, senior medical advisor at the Centre for Addiction and Mental Health in Toronto. As I welcome everybody, both here in Toronto and on the line in Providence, Rhode Island, to the program tonight, I think our great challenge is to have a discussion about depression without depressing the hell out of our television audience, which we will do over the next hour. I feel very confident. David Goldbloom, to you first. I'm sure you saw the study that just came out very recently saying that 38% of Canadian adults said they would be embarrassed to admit their child or teen had a mental illness, such as anxiety or depression. I'm going to get you to comment on that study in just 1 second. Before we do that, I do want to remind all of you who are watching us at home that you can get involved in the conversation tonight by emailing your questions to us at theagenda@tvo.org, and we'll get as many of them as we can to our guests throughout the course of the program. That email address, one more time, there it is at the bottom of the screen, theagenda@tvo.org. What do you think about that? Now, when you first saw that number, 38%, what did you think?
I was actually surprised at how low the number was. I thought it actually reflected a positive attitude shift, that it was only 38%, as horrible as that is for those kids who are affected. Because the reality is that there's nothing that threatens our sense of who we are as individuals than an emotional or a psychiatric disturbance. And for the people who experience it, what they experience is not only the symptoms themselves, but also the double burden. The double burden being the stigma and the discrimination, the shame, the secrecy, the silence.
Jody Lofshe, the numbers actually did get higher. When you look at higher education and higher income levels, there was no better understanding or acceptance of it. 40% of university-educated adults surveyed, 45% of those earning incomes more than $100,000 claimed they would be too uncomfortable to get help. Your thoughts?
That's not surprising. I think the more education or the more success one's had in life at overcoming certain life challenges, the more sense you feel that you can overcome any kind of personal challenge as well. And depression can be experienced as a kind of personal failing without understanding that it is a treatable illness. So that doesn't surprise me that I don't think there's any correlation between educational level, income level, and acceptance of depression as an illness.
Brenda Smith, you are here tonight as a bit of a trailblazer, I must say. You are a family physician from Curtis, Ontario, just outside Oshawa. You have not only suffered from depression, you have gone public about it. You have written an article about the fact that you're a doc and you suffer from this. Why'd you do that?
I think that for a number of years I had suffered intensely from chronic depression, had undergone significant treatment, even at one point having had ECT.
Electroconvulsive therapy.
Electroconvulsive therapy, which was extremely effective for me. At that point, after which I really felt to myself, you know, what do I have to be ashamed of? I have nothing to be ashamed of.
Did your patients know?
It's hard to know. Probably some of them did. Certainly my colleagues did.
They did know?
Oh, absolutely.
Did they hold it against you?
Generally speaking, I would say that I've had tremendous support from my colleagues. I think that at times, like anybody, there has been a tendency to hold back a certain degree of fear, a certain degree of isolation, not knowing what to say, not knowing how to help. And I think that that's all a part of, you know, of the illness.
But you wrote the piece, I gather, in order to get others who are in your shoes to not be afraid to come forward. How's been the reaction?
I really felt at the time that, you know, as family docs, here we are, we're educated, motivated, articulate individuals. And if we cannot, as a group, stand up and say that, look, depression is just an illness like anything else, then how can we not get other people to also have that sort of view?
Well, here's where I go to Providence, Rhode Island. I bring in Peter Kramer, because the study we're talking about here concludes that families feel responsible and they think it's their fault. It has been 14 years since you published Listening to Prozac. much of the research suggesting that there is a genetic basis for depression. Do we understand, in your view, what depression really is?
We do and we don't. Depression looks to be more like 35 or 40% genetic. A lot of it's environmental. Some of the environment is what you imagine, serious losses, trauma, childhood trauma, sex trauma. So there clearly are environmental causes. Some of the environmental causes are probably unknown, things that go on in the womb, random events. So it's complex in its causes. I think we have a better and better sense of what it looks like in the brain. We have a better sense of what it looks like throughout the body. This looks like a multi-system disease. It affects the way the bone is formed. It affects your risk of stroke and heart disease and recurrent heart disease. So it looks very much, certainly in its severe forms, like a quite ordinary disease, similar.
Okay, but on numerous occasions you have debated other people who have said depression is not an illness like cancer. You can't sort of, there's not necessarily a consistent medical treatment in order to take care of it. Are we any closer to a medical model of depression?
Yes, I think we are. I think that debate really is over for people who are serious about it. I think once you see differences in the brain of depressives on autopsy, once you see responses both to psychotherapy and to medication, I think we have fairly standard treatments for depression. We're not very good at treating it. I think we, do a good job with 30, 40, 50% of people, and then a fairly good job with another probably 30%. And there's a percentage of patients who just are very, very hard to treat.
Well, you say the debate is over, and yet the guy sitting beside you, I'm not sure, agrees with that. Gary Greenberg, in the current issue of Harper's, you've got an article with a quite provocative Chomsky-like title, if I can put it that way, Manufacturing Depression, a journey into the business of melancholy. In what way do you see depression being manufactured?
Well, everything that Peter's saying is undoubtedly true. All of the biochemical events that take place to help us feel depressed undoubtedly happen, and it may be that some people are better at avoiding those, or some people are better at creating those biochemical events in themselves. Where I think we part ways is in whether or not that qualifies as a disease. And I don't mean that at a scientific level, because it's hard even to know in science how to define a disease. What I mean by that is whether or not it helps us, on balance, to call depression a disease.
To that end, I want to bring Erick Fabris into the conversation right now. You yourself have been a patient on this field. You are also, however, suspicious of the notion that depression is an illness. How come?
Much the same idea as what has just been presented. I think that once we look at it as a biomedical condition, we tend to lose a lot of the will and the agency that we could bring to the picture. So we stop looking at it as our life, and we begin to look at it as a condition. And as long as we have that condition, there's less that we can do to really manage it from an experiential view or from a practical view. Of course, there's ways to mitigate symptoms, there's ways to decrease some of the negatives, but the overall picture seems to be, whoa, that's not my problem anymore. It's just part of my condition, it's part of my body, it's part of my physicality. On the other hand, I don't have to really worry too much, because whatever happens to me now is essentially not determined, but something that's already in line with what I am.
So did you or did you not see your depression as being somehow genetically based?
I certainly bought the line at the beginning. When I was first introduced to psychiatry in the hospital, I certainly understood my illness to be a lifelong disease that I would never be able to get off medications for, and so on and so forth. Of course, now I haven't been off or on medications for a very long time. But there's, and people will say, well, then you were misdiagnosed. And, the problem is that we have experiences that can't be explained in medical terms all the time. And I think that when medicine tries to explain them by giving them labels such as depression, as though depression is the same for everyone, or as though it has a similar basis for everybody, it's very difficult to grow forward from there.
And one more. Erick, I introduced you off the top of the program as a psychiatric survivor. What does that mean?
Psychiatric survivors are people who believe that they have survived the psychiatric system rather than benefited from it. The reasons being political, economic, and so forth, but also just very practically speaking, psychiatry doesn't offer the kinds of help that often we can find in society or in practical therapies, art therapies, whatever So in psychiatry, especially when I was in, and certainly still going on today, there's sort of a steamroller effect. People need medication. They are given medication, sometimes coercively. There's very difficult problems with that when it comes to actually growing in your own skin and trying to be your own person.
Well, you know what? We have significant chunks of the system at this table today, so perhaps we should give them equal time. David, you heard what Erick had to say. Your response?
Yeah. You know, a lot of medicine is based on a very core principle of pattern recognition. So that when we look at diseases and disorders, whether it's a heart attack, whether it's depression, whether it's a stroke, whether it's diabetes, there are a predictable set of symptoms and signs that occur that allow us to make a diagnosis. And depression can be quite numbingly predictable in terms of the symptoms that emerge when people experience the phenomenon of depression. Now, I think in Gary Greenberg's article, it's almost a little chilling the way he describes the experience of being shoehorned into fitting into a pattern of symptoms, that you almost feel his individual experience being sucked away as he's fit onto a prefabricated shape of disorder and disease. I have to say, though, I believe very strongly that in psychiatry, what we're trying to do all the time is to marry a highly reproducible pattern of symptoms with the unique trajectory of any one individual. And that should not deprive any person of agency, of activity, of responsibility, of engagement. It's not an either or. Either you have depression or you're your own person. So I have trouble with that dichotomy. And I think that in the best kind of clinical care, people do feel a sense of ownership, of responsibility, of agency, of participation.
Okay.
And there are examples where that isn't the case.
I should give Gary Greenberg a chance to follow up on that if he wants to.
Well, yeah, two things about that. It's true, and we have to remember that the people who shoehorned me are some of the leading psychiatrists in the country. They're at one of the top hospitals in the country. They're conducting valuable and expensive research on depression. If anybody should be good at diagnosing depression, it would be those doctors. So I think that's a really important point. And I don't know that I don't believe that it's polarized between, on the one hand, the idea of human agency, and on the other hand, the idea of biochemical processes. I just think that the disease model inevitably skews the picture in the direction of biochemistry. That's what it's there for. That's how medicine understands those patterns that it recognizes.
Jody Lavshy, is that legit?
Here,
let me get Jody to respond to that. Go ahead.
I think there's a lot of truth in the fact that one makes a diagnosis and it, with a certain set of criteria, that creates a system for understanding it. I don't think it shoehorns anybody. I think there's a great heterogeneity in terms of the way depression presents and the way people are treated that recognizes the individual in the experience. And I think that's the uniqueness of psychiatry, and the beauty of it is that each person who experiences depression is an individual and is going to bring their own life history and unique presentation to the picture, and therefore treatments should be equally individualized. And from medications to psychotherapies to the types of psychotherapy one chooses, it's going to be very much determined by the person.
Well, let's get another example here. Brenda Smith, who diagnosed your depression?
I was doing my PhD at Queen's University and started to experience academic difficulties, and presented myself to the medical health center, and was fortunate enough to have a family doc see that there were some really significant changes that I was experiencing, and therefore referred me to a psychiatrist, and thereby I was diagnosed.
So you've been living with this for how many years?
25 years.
25 years.
Yes.
You're on medication right now?
Yes.
You are?
I should also say that I have a very, very extensive family history that goes back many generations. So I think that, that also is a factor in looking at, my diagnosis and the likelihood that, in fact, I was going to suffer from a mental illness.
So you have no doubt that there's definitely a genetic component to what you're going through.
Absolutely.
Does the medication you're on help?
Well, I have a PhD in anatomy, and I'm a practicing family doc with a full practice. I have a large group of patients who I care for, so am I any different than anyone else?
But does the pharmacology get the credit for that, or is, where do the drugs
Are you going to,
stop getting the
if you're
credit?
asking me, can you split off who I am as a determined individual that is going to go forth and do what I desire to do in my life, and how the medication helps me do that? I don't think you can split that apart.
Eric, you want to comment on that?
Yeah, I do. I have to say that the debate about whether it's an illness, whether it's biological or not, might not be as central as we think. I think that sometimes we forget that there's a social component to this, and that a lot of people who suffer emotional upheaval or suffer experiences that they don't understand won't get the support that they need. The thing that really prefigures into this, though, is that the medications are not necessarily a magic bullet for everybody. In fact, as many studies have shown, they're just as effective as placebo most of the time. Sometimes placebos are more effective than they are. There was a study that showed that St. John's wort and I believe it was not Paxil, was it Paxil, were both just as at about 25% success rate in a clinical trial, but 32% of people got better on placebo alone. And when you look at that, you look, well, there's a third of people, and I hope I'm not simplifying this, but a lot of studies have shown this, and certainly it's well known that pharmacological companies need to present evidence that's good. What they often find is that they'll have to do numerous studies before they can come up with two studies that show, yes, indeed, we have something that's actually more successful.
I need to get Peter Kramer to comment on that. Dr. Peter Kramer, what you just heard, go ahead.
I feel like I've said too little already. I think we should say that the notion that depression or something like it is a disease is not a fiction made up by drug companies and modern psychiatrists. Hippocrates thought that melancholy was a disease, and really in every generation there has been a medical view of, as I say, something with pretty much the shape of what depression has today. The medications are pretty good. I think a fair view of the research overall would say that they're reasonably good, and I think where they fall down often is in the initial drug company research, which is sort of quick and hungry because they want to get in under the patent deadline, and they do probably take in too broad an array of people. They have very high placebo effects, probably because they're not seeing people with real depression. I think we also ought to say what this syndrome is that has been recognized for centuries, just so that your viewers know. I think if people are sad, they're unable to enjoy
You know what? Let me
things.
jump in there. Sorry, I'm going to jump in there because this is a
please.
great time to quote the Bible. The Bible is the diagnostic and statistical manual. And there are, in fact, 9 points where if you've got these, then you are depressed. So let's give the list right here, and that way we're all on the same page, including our viewers. Are you depressed? Well, you're depressed. If you're depressed, sad, tearful, that's count 1. Number 2, diminished interest or pleasure in daily activities. 3rd point, increase or loss of appetite. Number 4, insomnia or hypersomnia nearly every day. Number 5, agitation or restlessness. Point 6, fatigue or loss of energy nearly every day. Point 7, feelings of worthlessness or excessive or inappropriate guilt. Point 8, diminished ability to think, concentrate, or make decisions. And finally, point 9, recurrent thoughts of death or suicide with or without an attempt. Now, again, Peter, how many of these 9 do you have to be suffering from in order to be thought of as being depressed?
Let me add one set of criteria which I think really are going to be part of the discussion tonight, which is severity. These symptoms, when they add up, have to interfere with your ability to work, take care of your children, interact socially. They have to cause you a substantial amount of suffering. And I think that severity criterion is where a lot of confusion comes in, because I think people can say, well, I have sleep and appetite problems all the time. I'm not very happy. But anyway, to make the diagnosis, you need to have that level of severity, and in addition, 5 of the 9 symptoms, and at least one of them has to be this sadness or inability to experience pleasure. And this is not a terrific definition. I mean, we know depression when we see it, right? People who can't get out of the chair, they're wringing their hands, they say terrible things about themselves. We talked about the stigma of getting treatment. In addition to the stigma, people feel that it's their fault, there's no hope, so there are even higher barriers to getting treatment for people when they're actually in the state. So that's what it is. And this, Chinese menu version of saying what depression is has just been fixed upon because it does a pretty good job of finding those people who are really going to have a long career of that kind of experience.
Okay, I want to get a sense from Jody Lofsche, because if you're doing emergency services at the hospital, where are you, out of the Western Hospital
That's
in
right.
Toronto? Then you're seeing the worst of the worst, I imagine, come in the door. What are you seeing?
Well, it's very interesting because often the patients who do come to the emergency room aren't coming in complaining of depression. That depression can present without somebody being quite aware they're depressed. So many people come in with medical problems, with somatic complaints such as stomach upset or headaches or weakness or dizziness, or secondary problems related to the fact that they're not sleeping and eating. And it takes an astute emergency physician to say, wait, there's nothing medical going on here. I think maybe this is a bigger picture, or I'd like psychiatry to have a look. And again, we can talk about stigma after, but at times people are quite shocked that they're being referred on to psychiatry. Other times it's the family who notices, this is not my loved one. Something is different here. They don't want to engage, go out, do anything socially. They can't get out of bed, or everything's so negative. And it's the family who might notice first. And it's great if they can convince the family member to come in and talk to somebody, but I've seen people come in under false pretenses where the family says, just come in for these reasons, and they get them in the emergency room, and it's like, we're really worried because we're worried they don't want to live, or that everything is so different, and it's the family who has the agenda.
But I've seen this work both ways. There are those who would allege that people would kind of like to be diagnosed as depressed because it's kind of a cool in thing to have.
Okay. So there's another patient
yeah.
population that uses the emergency room maybe sometimes too frequently. And there are people who are having life stressors who have problems coping. And that's understandable. Whether or not they should be in the emergency room or seeing family physicians is another story. But they become overwhelmed, and they are in an acute state of a crisis, and they may have some of these symptoms of depression that Dr. Kramer was just describing, but they don't have the time frame of at least 2 weeks every day for most of the day, that it's more situationally based. And often they say, I'm really depressed, maybe I need an antidepressant, or can you find me a therapist? They want the label, but they don't meet the criteria. So we're not quickly putting people on medication, quickly making that diagnosis, unless we are convinced that this has been going on for some time and it is affecting the functioning. So there's a huge range of patients who come to the emergency room. Clearly, as a psychiatrist in the emergency room, the issues I'm most concerned about are safety. That when people are that depressed, that one of the criteria and one of the sort of sequelae is not wanting to live. And that's part and parcel of every emergency room assessment, is a risk assessment, safety about themselves, or if they're having horrible thoughts of taking someone else's life, because, and for postpartum depressions, that's especially important, about asking about thoughts about taking the baby's life with them, because if this world is so horrible for them, then perhaps they're going
to take the kid with.
But Steve, I think at least some of the confusion comes out of the fact that depression is a word that is now diluted out of meaning, because we all use it as a more sophisticated piece of vocabulary when we're upset or when we're sad. People say to me, I'm so depressed the Maple Leafs aren't in the Cup again this year. Well, they may be upset, they may be annoyed, they may be angry, but it's light years different from the actual experience of depression in a clinical sense.
You know what,
with
though?
every patient that I see, I'll ask them, from your own vantage point, what's the difference for you between feeling sad and feeling depressed? And for every patient I've seen who's actually been in an episode of depression, the distinction is made in a heartbeat for them. Sadness is a normative human emotion, and they can distinguish it from the sustained depression. It's a very different mood feeling, at least in the people I talk to when I ask them this question.
You do know, though, that it's been 40 years since the Leafs won the Stanley Cup. It may very well be depression.
Sustained.
Yeah. Brenda, what does it feel like to be depressed?
Actually, it's been such a long time, sometimes it's hard to differentiate it. I certainly pretty much experience all of those 9 points in the Bible on a day-to-day basis. Sometimes it's worse. Sometimes it's difficult for me to get out of bed in the morning. Sometimes,
Still, even on the medication?
yes. Sometimes it's very hard for me to concentrate. I've adapted very well. I adapt very well. I use all sorts of tools to help me with my memory. I keep my life very structured. I basically adapt.
How you doing?
Not too bad.
Yeah? Mm-hmm. You think without the medication, where would you be?
I wouldn't be functioning. I wouldn't be working.
You literally could not function.
I could not function.
We have an email that's come in to theagenda@tvo.org, and it's from Colleen, and it says, is there a correlation with depression and gender? Gary Greenberg, how about it? Correlation between depression and gender?
Well, I'm sure there's people on the show who know those statistics better than I do.
Okay, who do you want to pass to?
Peter?
All right. Peter Kramer, go ahead.
It's pretty much 2 to 1 women to men, and this is in surveys that find more alcoholism in men. They find equal rates of manic depressive illness, which we haven't discussed. I think the medical model at least sees that as a separate condition. That seems equal in men and women. And it's a complicated discussion why it should be more women. Some people think women have more chronic stress, they don't have more acute stress. Some people think women have more attachments and suffer more losses because they count more people as being close to them. And some people think there's a genetic or biological relationship to things that get women to be more attached and punish them more for ruptures in attachment. Women tend to have the first episode of depression earlier. Once depression starts, next episodes come as frequently for men. So a lot of the reason women have more depression is they get depressed younger.
Some people also think that women are oppressed. I mean, our society is not very fair to women, and so this is one of the problems that women exhibit it through depression, perhaps some people say it, and men exhibit it through aggression. So, we're not also, I'm sure that there are many patients at the Center for Addictions and Mental Health who would not see a difference between sadness and depression, who actually do see their depression as a great state of sadness, I mean, when we look at somebody who's lost their ability to function in our society, which we seem to think is a natural, bona fide, the only way that society could ever operate, we're looking at somebody who maybe has taken a left turn and has slowed down and doesn't want to participate at the same rate as everybody else. But I don't know why this should appear to be malfunctioning. I think that this is a natural part of living. The other thing about
Steve, if I may.
Sure, go ahead,
Gary
please.
Greenberg in
Yeah,
Providence.
go ahead, Gary.
I think that point is pretty important because you can take everything that's present in the disease model of depression, all the criteria, all the biochemistry, everything that's there, and you can grant that it's all true. And you're still stuck with this very strange number. 2 times as many women as men have depression. Now, of course, we might find some biological reason for that, but we do know that there is this great distinctions between men and women, many of which are social and political, and it seems like it would at least be plausible to consider the possibility that that indicates that there's something in addition going on here, not something other, but something in addition to this biochemical / genetic pattern.
Any theories about what that is?
Well, I think that, I'm sorry, I don't know the fellow's name. It's he's far away, and who just
That was
made
Eric.
point?
Hi.
Erick
Eric.
Fabris, the psychiatric
Eric.
survivor.
Yeah, well, Eric, I think Eric's in the neighborhood of one way to look at it. Another way to look at it is that depression is a way that we have of getting a handle on emotions or on an experience. It's very disconcerting, and that it could be that that label serves the purpose of helping people focus on their pain and their suffering in a way that helps them address it.
I do want to
So-
pick up on a thought, though, that Eric had a moment ago, which was the connection between the psychiatric field and pharmacology. I'm not sure you put it that way, but I want to explore this relationship a bit, and David Goldbloom, I'll bring you in at this point. We were quoting from the Bible a second ago, this diagnostic and statistical manual. The original manual in 1952 contained 107 different diagnoses. Now, in 1994, the manual contained 365 conditions. That's 340% increase over 42 years. And the question is the psychiatric establishment in cahoots with the pharmaceutical industry to medicalize personality traits that should be left alone?
It's a very legitimate question. There's no question there's been an exponential increase in the number of diagnoses. And in fact, if you go back even earlier, before the first manual, there was a view in psychiatry, particularly during the dominance of psychoanalysis, the diagnosis didn't actually matter at all. The only thing that mattered was understanding the individual, although that understanding of the individual was also based on a model of a template of psychological understanding that was then imposed on the experience of the individual. It's very hard to get away from pattern recognition. There has been an explosion within psychiatry of diagnosis, and a lot of us in the field are concerned about this mushrooming outward of specific categories and subcategories with real questions still unresolved about the validity of a number of the categories. And it's based on an effort to try to describe phenomena that are observed and then see if you can replicate or reproduce that finding in other individuals who are suffering in one way or another.
Okay, but you started your answer by saying it's a legitimate question, but you never actually denied the premise of the question. Do you think there is some cahoots going on here between psychiatry and pharmacology?
Well, I think there are cahoots to the extent that psychopharmacology, drug therapy, and psychiatry over the course of the last 40 years has offered new treatments and indeed new hopes for people who have traditionally suffered with a whole variety of psychiatric ailments. And so that new hope comes with new enthusiasm. And new enthusiasm can lead to over-enthusiasm. There's no question about that. William Osler said about new medications, use them quickly before they lose their effectiveness, because the lure of the new, whether it's a new technique for psychotherapy, and we see this as well, when a new model of psychological treatment becomes developed, suddenly it seems to work for everything. It's an absolute cure, and then people start to scale back. I think we've had some of the same phenomenon in psychopharmacology, but driven by a desperation to find new ways of helping people. The cynical view that this is all a money-making, multinational corporation scheme that is driving the process, to me, just kind of obscures the fact that there are people out there who are in great distress.
Okay, well, hang on, Eric.
And we've got to find a whole variety of ways, not limited to drug therapy.
I want to hear from Eric, and then I want to go to Rhode Island. But
I was going to say that maybe...
do you sign on to the way he described it, first of all? Are you that cynical person he's talking about?
I don't think I'm very cynical. I think I'm actually following a little bit of the science on this. In fact, the American Psychiatric Association president recently said in 2005 that he did see communion between those two forces, and he did say that it was turning from a psychosocial model into a bio model of distress and living and so on. I mean, he's certainly not looking at it the way I am as something that happens to people, but he's certainly aware that all the kickbacks and all the schemes that the pharmaceuticals have for doctors and medical profession does lend to some of the problems that we're experiencing in institutional and community psychiatry. We're not keeping people on their medications because they're horrible to some degree. I mean, there's a lot of people who have very negative effects. And these effects are not necessarily just side effects, unintended effects. These effects are what tends to happen when you block certain neurochemicals in the brain. I mean, there's...
I heard Rhode Island wanted in. Go ahead, please.
Hi. I think that we're taking a very narrow view of medicine. I actually agree with Eric that the medical profession is very worried about the effect of large pharmaceutical companies. That is what is expressed by the leaders in the field. I don't think that that's outside medicine. Likewise, I think that behavioral treatments, whether they're for high blood pressure, there were old studies that group therapy was helpful for tuberculosis. I mean, these are very much part of medicine and have been for years, it doesn't make depression odd or unique, that it has a behavioral aspect, that stress worsens it, and so on. I would like to say something that has less to do with drug companies, though, which was, as David Goldbloom said, in the United States, manic depression was almost never diagnosed at a certain moment in the 1950s. People asked, why is there so much more manic depression in England and the UK than there was in the States? And did a study and found that, in fact, there was exactly the same amount. American doctors just weren't diagnosing it until an Australian physician discovered that lithium, a salt, something that drug companies don't make a lot of money on, was very good for preventing and interrupting manic depression. And then all of a sudden, there was a lot of diagnosing of what's now called bipolar disorder in the States. So it's not all a drug company scheme. It really is the case that as you get better and more effective treatments, people start diagnosing the ailment because they can do something about it.
Well, let me follow up with, all right, sorry, Gary, you wanted to say?
I have to agree that it's not a conspiracy for the most part. I'm sure there's conspiracies out there. I mean, there's a lot of money at stake, so there always are conspiracies. But I don't think in general it's a conspiracy. It's an association of advantage. For instance, the DSM criteria for depression are important, but much more important to the drug aspect of this question is a test called the Hamilton Depression Rating Scale. That's the test that's used in the States anyway to seek approval for antidepressant drugs. That's the test that you have to show improvement on in order to say that your drug is effective. Now, there's no question that the Hamilton was developed in order to measure the effects of antidepressants. It constructs depression in a way that makes it, that looks for the things that the drugs will help. 10 of the 17 items on the Hamilton are neurovegetative symptoms. Things that drugs were, not only were drugs in general likely to help, but the guy who wrote the test knew that the drugs that he was working with helped those things. 7 of those items have to do with psychological questions, but those psychological questions are so poorly posed and so difficult to answer that they're nearly meaningless. So you don't have to posit a conspiracy, it's just that that happens to be the way that the thing works.
Understood. Got an email here, and Jody Lofshin, let me put this to you. Email says, if one begins taking antidepressants and they help the condition, can one eventually be taken off the medication one day and function just as well without meds, or does the brain begin to depend on the meds?
Because that's a complex question in terms of who's taking the medication and what their history has been. And the current, I mean, there's 2 parts of the question, and there's many fears that antidepressants are addictive, or one becomes tolerant, and if you stop them, and you'll go into some sort of withdrawal. And that's not the case. There are problems about coming off medications too quickly, and especially for some of the antidepressants, it can be unpleasant to stop them abruptly, and one would need to come off slowly. But what's more important is understanding that particular individual's past history of depression and how many times they've been ill. And for many people who suffer from recurrent episodes or chronic depression, it's not in their best interest to come off a medication if it's helping them and there's no side effects. And many people would rather stay on it if it's working. Why stop it if there's been recurrent episodes? Because what we're seeing with experience is that if you stop and start and stop and start, it's actually harder to get a response the next time you expose somebody to the same antidepressant. They may not do as well. And that actually their episodes become more severe or more frequent. And so the thinking is if somebody's had a history of more than a couple of episodes of depression, then it's probably in their best interest, if they're on a good medication, to stay on that.
Stick with it.
Yeah.
Let me ask Brenda about that. Do you look forward to a day when you will not have to take medication anymore?
I guess I've actually come to a point, having had, as Jody referred to, multiple episodes of depression, that at this point in my life I would not choose to stop my medication.
So you expect basically to be on this for the rest of your life?
Yes.
What are you on? Can I ask? Am I allowed to ask that? You don't have to tell me if you don't want.
No, I choose not to.
Okay. But it works. That's the main
Just
thing.
To, again, make an analogy that just like people who have diabetes need to be on insulin, this is something, again, I know it's a medical model, but we see this as a chronic condition that if there's a medication that can help, why deprive oneself of it? If it's working, you know, then we would not recommend somebody comes off a medication if they've been, again, based on their past
It
history.
doesn't always work. And in
Okay,
fact,
then
in some
that's another
cases,
situation.
When it doesn't work,
well,
it's a
it
different
doesn't
story.
work in most of the situations. That's the problem. And in fact, in some of the
I don't
situations,
think she agrees with that.
I don't agree that.
in most of the situations, 30% of the time we might see an improvement, right? And after that, I'm not sure what we see. We see some people just stay the same.
Well,
Some
as
people
Dr.
get worse.
Kramer said earlier,
That's
it's
the
probably
worst
the
part.
30% that we can't treat at all. But I'd say more than 60% we can help in some way through either medication,
doesn't work
psychotherapy, or a
with-
combination.
That's not what I read in the literature. The literature says that about 30% of people improve on these drugs. There's
No, I think what the literature says is that 30% of people will experience remission of depression, and another 25 to 30% will experience symptomatic improvement, but not remission. In other words, their depression gets better, but it doesn't go away. They're left with some residual symptoms. And I think one of the challenges in some of the sort of integrative treatments look at what are the elements, for instance, in cognitive behavioral therapy that will address specific symptoms of depression that are less effectively touched by antidepressant therapy.
There's
What are
also
the things that
negatives,
prevent
though.
against relapse?
That last third of people who actually get worse
Right.
on a medication, that's
No,
another problem.
it's
I mean,
not
when you
that
look
a
at
third get
Luvox
worse.
as an
A third
example.
don't respond at all to an antidepressant. And for those people, the same
I've
with,
not heard that.
The
I mean,
same with any
there are
other
people
treatment.
who actually get worse on medications.
That's maybe the nature of the
Absolutely.
illness.
Look at the shootings down south. I mean, there's a couple of examples in which, in one case, we had a person who was on Luvox. In another case, in the recent case, we also know that antidepressants were in that person's life. Now, I'm not sure if there's a withdrawal problem or if there's
That's
a
a
negative problem.
correlation. That's not causal.
No, not
There's no
necessarily.
evidence that the antidepressant
But just
would
can I
cause
understand this?
recently found out.
Obviously, I presume all three of you agree that if the stuff isn't working, you don't stay on
Correct.
it, right? You all agree on
Correct.
that?
Correct.
Okay. I want to play some tape here. Michael Smith, can we play the nice, you know, I like to find consensus every now and then. Let's play this clip if we can for a second. The World Health Organization is forecasting that by the year 2020, depression is going to be the second most widespread disability in the world. And here's what the University of Wales's David Healy had to say about that. Michael, roll tape, please.
The World Health Organization has come out and said depression is the second greatest source of disability on the planet. The response from psychiatry is not what's going on. I mean, if any other serious illness had come from nowhere in the 80s to being the second greatest source of disability on the planet, people would be asking what's going on. The response from psychiatry is, whoopee, we're the second most important people in medicine after the cardiologists, and we're going to pass them out soon.
Peter Kramer, do you believe that prognostication?
I don't know if the prognostication's right, but if you cut it by half, this would still be a very, very serious problem. The way you get that prognostication is that this is a condition which occurs in every country where it's been studied, and it comes on young. And there just are not that many chronic recurrent conditions that are severe when they're at their worst and that come on, you know, in the late teens. So this is lifelong, and it gives you a lot of days of disability, and that's what the World Health Organization and, frankly, the International Monetary Fund, both looking for, you know, where should we put health dollars in developing countries as well as developed countries. They were looking at what really, you know, keeps people out of work day after day.
Even if it's not
And
that
as
exponentially big, though, even if it's just the kind of increase that you're talking about, what do you think explains the rapid increase in depressive illness?
I don't know that there is a rapid increase. I'm one of the people who's very skeptical about that. I think that if you look at literature, if you look at 19th century literature, if you look at 18th century poetry, you see an awful lot of what looks like modern day depression. And I think some of the more sophisticated recent studies say this just has been with us, and it's not you know, an epidemic at the moment. It's just something that there wasn't much to do about it until recently. Except I will say that, you know, psychotherapy, 100 years of psychotherapy probably has been very useful, as well as medication. And I think that also is the medical view. The medical view isn't that only medication is useful. It's that psychotherapy is sadly underfunded and understudied, and we'd like to do better with that as well.
Well, in fact, we just
I
got an
think
email to
that's-
that effect. Let me just read the email if I can here, because Matthew just sent in an email saying, what can be done to make cognitive behavior therapy more accessible to people who can't afford to pay for it? David Goldbloom, you want to take a kick at that?
Sure. Just looking at the University of Toronto Psychiatry Residency Training Program, which is the largest training program in North America now, all of our residents get training in cognitive behavioral therapy. That would not have happened 10 years ago, that they would not have been trained in this psychological treatment intervention, and all of them as practitioners are publicly funded through OHIP. There are increasingly the development of family health teams in Ontario that are publicly funded, where it's very conceivable that among the multidisciplinary professionals working in a family health team, we'll have people with skills in cognitive behavioral therapy, interpersonal therapy, family intervention.
It's getting there, you're saying?
It's getting there. It's still an uphill battle in terms of access. There are not enough skilled practitioners of a variety of disciplines available to help people with these problems.
Gary Greenberg, can I get a comment from you on that, the accessibility of this?
Yeah, I think that it's important to look at cognitive behavioral therapy because it's the most explicitly political therapy that's out there. Cognitive behavioral therapy is the power of positive thinking put into an empirically testable form. And as a result, what it really is it's a therapy that pathologizes pessimism, calls pessimism maladaptive thinking. Now, on the one hand, that's very comforting, and sometimes that's really important for people who are stuck in the kinds of depressions that people here have described so vividly. But on the other hand, there are possibly some reasons, and I don't just mean mortality and so on, that people might want to take their pessimism seriously and not want to explain it away as a symptom.
Brenda Smith, do you see more mental health problems or patients with mental health problems coming through your door these days?
I actually have a very large practice of mental health patients. But one of the things that I'd like to address that is some of what we've been talking about is disability. And I think we need to spend more time talking about ability, because people with mental health problems can be as functional as the regular population. And, you know, I think of myself in that respect. I mean, I have a severe mental health problem, and yet I am able. And when I speak to my patients, one of the things I spend a lot of time talking to them about is how important it is to take that aspect of their life that is strong and functional and use that so that they can stay functioning in society, and that we deal with the disease and the problems separately.
David Goldbloom, is there any reason to believe that the complexity of modern life, more freedom, autonomy, all that kind of stuff, might actually be a condition which creates conditions conducive to depression?
Well, what are the alternatives? I mean, realistically, even if the answer to that was yes, unless you've got a time travel machine, this is the world we're in. Now, people in the 21st century era of technology, for instance, have encroachments onto their personal and private lives that never existed for a generation before us. Suddenly they're connected through their PDA, through their fax machines, through their cell phones to the world of work that sort of bleeds out into personal lives. There are challenges with these kinds of changing technologies for our personal satisfaction, our personal sense of well-being, but does that all contribute to this phenomenon of depression? Whatever we believe around this table, its origins to be or its manifestations to be, I don't know.
Can we talk about...
I really don't.
I'm not sure I've ever heard of, a mental health expert answer a question, I don't know. That's good. I don't mind hearing that every now and then. Go ahead, Brenda.
Can we talk about stigma?
Sure.
You know, what is the actual stigma of the disease?
Do you mean discrimination? Just out of curiosity, because that's what I would call stigma.
Well,
discrimination.
did you look stigma up in the
I certainly
thesaurus
did.
last
Marking
night?
and all of that?
Yeah, blemish,
Yes.
sore,
But isn't that discrimination?
mark. I don't know if it's discrimination
You're
or
right,
not.
actually. It's not. It's more the person's stigma,
Yes.
not society's
We're
discrimination.
talking
You're trying to
about
say it's something
fear.
more, Brenda?
We're talking about fear, isolation, and malignancy. This is one of the most malignant diseases out there. It's more malignant than cancer. And yet I don't think that people in the population realize how malignant this disease is and how much it eats into the life of the individual
Just
and
explain
the
that for a
family.
second. What do you mean it's more malignant than cancer?
Well, I have cancer. So
You have
I
cancer,
have,
too.
I have ovarian cancer, and I have severe depression. I'm in 5-year remission. Now, when I had cancer and I was fighting that, I had flowers, I had people at my door, I had people cooking meals for me, I had, people at work, rah, rah, here we go. When I'm depressed, isolation, people don't call, they don't know what to say, they don't know how to help, they don't know how to reach out. It isolates you. There's a fear. There's a fear within yourself, there's a fear on the outside.
But neither condition that you have is contagious, so why would you get such different reactions from people?
Well, I think it's a lack of understanding. I mean, here we are, the brain, one of the most complex organs in the body, and how much do we really understand about it? There's the mystery and the mysticism of the brain. It's our soul, it's our personality. And then here we go talking about this disease that affects that so much, and that scares people because they don't want this. This scares them, whereas cancer can be cured.
Jody, do you see this?
I think you make a very important comment on the meaning of the mind and the brain and the connection to the sense of self. And you can't separate that out. Cancer, you can isolate an organ and you can try to distance yourself from that, and you treat it or you don't treat it. But what is so threatening with a mental illness is the fear of losing oneself to that process and losing one's identity, losing one's sense of meaning in life.
What would it take to turn public attitudes around so that people brought flowers and people made meals and people took care in a different way of people with mental disorders? You've got your hand up.
I've got
Fire away.
Yeah, the Mad Student Society is an excellent example of people who actually do bring flowers when somebody's feeling down, or do try to give each other support and try to start a new language about talking about those things, rather than seeing them simply as discombobulations that are sort of physical and we let the doctors deal with those. Actually trying to bring up a language that can actually address some of the issues personally. And I think that that's one of the issues that's in our society. We don't know how to talk about sadness. We don't know how to talk about loss or grievance or any of those things. So as we're all competing and trying our best to do what we do, we tend not to actually listen to each other and to open up these conversations.
Peter Kramer, talk to us about stigma.
I find this hard to believe. I think we are the culture that most discusses emotion, most discusses it openly, in intimate relationships, on television. I find it astonishing to think that we may not handle it well, but we certainly are open about it. I wanted to bring together cancer and depression in a study that to some extent defends these cookie-cutter diagnoses. There's just this week in the leading American medical journal a study in which somebody who treats depression was put into 20 primary care practices. 20 other primary care practices ran just the way they had. And the elderly in these practices where there was active treatment of depression, starting with medication, there were fewer deaths from cancer. There were fewer deaths altogether. It looked as if intervening vigorously gave you less mortality in the elderly. So I think there is even something to be said for these fairly simple diagnoses. They do parcel out something that does pretty well when it's treated.
David Goldbloom, I'm down to my last minute. Are we ever going to see a day in this province where we don't have the kind of stigma associated with mental illness that we've just heard described from Brenda Smith?
I think the most we can hope for is less of it. I work in a hospital with 600 beds that has no gift shop. And it has no gift shop because there isn't the human traffic of people coming to visit people when they're feeling at their worst. And that everybody is within everybody's reach. We all of us in our families, in my family, in everybody's family, have somebody who's been affected in some way by mental illness. And we need to all stop for a moment and think, how have we avoided or marginalized or isolated that person instead of embracing them?
Some smart service club has got to put a gift shop in CAMH. Wouldn't that be a great idea?
Great idea.
Can I thank, first of all, in Providence, Rhode Island, Peter Kramer and Gary Greenberg for joining us on the program tonight. It's been a great pleasure having both of you gentlemen with us. Thanks so much. And to David Goldbloom, Senior Medical Advisor at the Center for Addiction and Mental Health here in Toronto. And to Brenda Smith, Erick Fabris, and Jody Lofsche. Great having you three alongside as well. Thanks a lot, everybody. This was not a depressing discussion at all. So I want to thank everybody for their help on this. For more information about tonight's guests and the subject of this discussion, please visit our homepage, tvo.org. Follow the links to the agenda. Tonight's program was produced by Sandra Jonas and Wojtek Schemberg, and you can keep this conversation going with them on their blogs, also at tvo.org.